Welcome to the Stanford Lymphedema Surgery Center. I'm Dr. Young Nguyen, Director of Adult Plastic and Reconstructive Surgery. I specialize in the surgical treatment of lymphedema. Here at Stanford, we understand that lymphedema is a challenging condition that results in significant physical and psychosocial impairment. While there's no cure for lymphedema, we offer a multimodality approach to treatment that can normalize the patient's lymph volume, reduces the risk of infection, improves function, and quality of life. In the subsequent video, we will provide an overview of lymphedema and the current treatment options. We thank you for watching this video in preparation for your upcoming consultation.
What is lymphedema? To understand lymphedema, we first need to be familiar with the lymphatic system. This is a schematic of the lymphatic and circulatory system. In the human body, the heart pumps blood through arteries to deliver oxygen and nutrients to cells. The nutrients and their accompanying fluid leak out of the blood vessels into the space where cells live, called the extracellular space, so that the cells can have access to this energy. The remaining nutrient-poor blood is carried back to the heart via veins. The protein-rich fluid in tissues, called lymph, is collected and drained in lymphatics. Lymphatics are a series of tubes that join together and ultimately connect with large veins so that the lymph can rejoin the body's circulation. Additionally, while lymph is being transported in lymphatics, it will be filtered through lymph nodes at certain checkpoints where the body's immune cells can monitor for and start the fight against infection. Lymphedema is a medical diagnosis involving an accumulation of protein-rich lymph in a particular area of the body which causes swelling. This happens when the transport of lymph is disrupted, often after the treatment of cancer, trauma, or infection. The fluid accumulates upstream from where the lymphatic drainage is disrupted, causing a backup of lymph in the body's tissues. This process can worsen over time, leading to changes in the quality of skin and underlying tissues. Additionally, because the lymph fluid is so rich in nutrients, the tissues can be prone to dangerous infections like cellulitis. Currently, there is no cure for lymphedema, but there are many treatment options available. Here at Stanford, we use a multimodal approach to optimize lymphedema treatment. What are the causes of lymphedema? There are two types of lymphedema, primary and secondary. Primary lymphedema stems from abnormalities of the lymphatic channels present at birth. However, symptoms may appear at any time. Lymphedema present at birth is known as Milroy's disease or congenital lymphedema. When the symptoms appear during puberty, it is called lymphedema praecox, and when symptoms appear in adulthood, it is termed lymphedema tarda. In secondary lymphedema, there is damage to the lymphatic system that results in inadequate lymph drainage. It is far more common than primary lymphedema. In less developed countries, this is often due to a parasitic infection. In the U.S. and developed countries, secondary lymphedema is usually a consequence of cancer treatment, including cancer excision, removal of some or all lymph nodes, and radiation therapy. However, it is important to know that not all patients who receive cancer treatment will develop lymphedema. In the U.S., about 10 million people have lymphedema. 90% are secondary lymphedema, and of those, 68% are cases related to cancer treatment. It is most common in breast cancer patients. Approximately 5% of patients undergoing a sentinel lymph node biopsy or removal of a few local lymph nodes develop lymphedema. This increases to 15% when an axillary lymph node dissection or removal of all lymph nodes is performed, and 40% when these patients receive radiation therapy as well. Patients who are treated for genitourinary cancer and malignant melanoma with removal of lymph nodes or radiation therapy can also develop lymphedema. This has an incidence of 20 to 49% and 20% respectively. Approximately 80% of patients experience the onset of lymphedema within 3 years of surgery, and the remainder have a 1% incidence of lymphedema each year. Other less common causes of secondary lymphedema include infections, trauma, inflammatory conditions such as eczema or rheumatoid arthritis, and cardiovascular disease such as deep vein thrombosis, varicose veins, or May-Thurner syndrome. Lymphedema can occur shortly after the inciting injury or even many years later. It usually appears in the arms or legs, but it may spread to other areas of the body, such as the neck, underarm, or groin. Next, we'll talk about lymphedema symptoms and staging. Common symptoms include swelling and discomfort. Over time, skin and nail changes develop, and affected limbs may feel consistently firmer. Some patients have pain, and as lymphedema worsens, it can result in disfigurement, physical disability, and an overall reduction in quality of life. Additionally, patients with lymphedema are at increased risk for infections such as cellulitis. Symptoms usually develop slowly and progress from stage 0 to 4. The severity of the condition worsens over time, and treatment becomes more difficult as the disease advances. Initially, in stage 0 or subclinical disease, no swelling is seen, but patients may have a feeling of heaviness or tightness in the limb. In stage 1 or mild disease, the limb becomes swollen, but it remains soft. If you push your finger on the affected area, it leaves an indentation. This type of swelling is known as pitting edema and results from excess fluid. The edema or swelling is reversible with limb elevation and compression garments. In stage 2 or moderate disease, the limb is more consistently swollen. When you push your finger on the affected area, it no longer leaves an indentation. This is called non-pitting edema. Furthermore, the tissues feel spongy. This happens because the protein-rich lymphatic fluid that has pooled in the tissues causes a chronic low level of inflammation, which results in the formation of excess fatty and fibrous scar tissue. This scar tissue causes more lymphatics to close down, which further impairs lymph drainage. In stage 2 disease, while there is still some excess fluid in the tissues, the swelling is more so due to the excess fibrofatty tissue. As such, swelling does not completely resolve with elevation. As time goes on, lymphedema will progress to stage 3, or severe lymphedema, where there is irreversible tissue swelling and the limb feels firm. The ongoing inflammation causes even more extensive scar tissue formation or fibrosis. The skin also becomes dry, flaky, thickened, and darker. There is an increased chance of infection because the lymph fluid is rich in nutrients that bacteria also use for energy. Recurrent skin and nail bacterial and fungal infections are common. The swollen, heavy limb may become difficult to move, affecting normal function and activities. Finally, in stage 4 lymphedema or elephantiasis, the limb is extremely large and heavy. The skin becomes very thick, and the limb often can be difficult to move. This is the most severe form of lymphedema. As you can see, the swelling from lymphedema is initially mainly due to excess fluid, but over time there is an increasing component of excess tissue that contributes to the size and heaviness of the limb. Lymphedema workup and diagnosis. Lymphedema is diagnosed clinically and confirmed with various diagnostic tests. In clinic, we will measure bioimpedance and limb circumference. Bioimpedance is a non-invasive test that measures the rate of electrical current transmitted through tissues in order to measure the amount of excess fluid in the affected limb. Measuring limb circumference at regular intervals can help us calculate the amount of excess volume as compared to the normal limb. The diagnosis is confirmed by lymphoscintigraphy, which assesses overall lymphatic function. This procedure involves the injection of a small, safe amount of radiolabeled substance into the web space between fingers or toes. A special imaging device detects the substance as it is taken up into the deep and superficial lymphatics. Images are taken at set time points hours apart to evaluate lymphatic flow. A venous duplex ultrasound is also required to evaluate the superficial and deep veins. This looks for other causes of swelling, such as blood clots and venous insufficiency. Back in clinic, we will perform lymphatic mapping using a fluorescent dye called indocyanine green, or ICG. This is injected just underneath the skin between your fingers and toes, and it is taken up by the superficial lymphatics. Using a device such as the SPY Elite or photodynamic eye, the superficial lymphatics just millimeters below the skin can be visualized in real time as the lymphatic channels fluoresce from the ICG running through it. This procedure is done before surgery, intraoperatively during some procedures, and postoperatively to monitor your progress. Lastly, CT imaging and lympho-MRI are occasionally used in the workup of lymphedema. CT can be used to assess subcutaneous swelling and calculate limb volume, but not often used. Lympho-MRI is a newer approach that can map the morphologic architecture of the lymphatic system with better spatial resolution. It can also assess fluid and fat composition. However, it is currently not being performed at all treatment centers. All patients being evaluated for lymphedema surgery at Stanford will undergo lymphoscintigraphy, venous duplex, and lymphatic mapping. Measuring limb circumference and bioimpedance are performed routinely in clinic to monitor the affected limb. Next, we will briefly discuss non-surgical treatments. The first step in treating lymphedema at any stage is complex decongestive physiotherapy, or CDT. Complex decongestive therapy consists of a decongestive phase and maintenance phase. In the decongestive phase, the goal is to decrease the swelling in the limb to normal or as close to normal while maintaining healthy skin. In this phase, patients work with lymphedema therapists as often as 5 days a week for 3 to 8 weeks, depending on how long it takes to bring down the swelling as much as possible. Once this is accomplished, the maintenance phase of CDT starts, where the goal is to maintain the results of the initial intensive phase on the patient's own. CDT includes the following components: meticulous skin and nail care, manual lymphatic drainage, which is a type of gentle massage to help open lymphatics and stimulate lymph flow, exercise including swimming if feasible, 24-hour compression bandaging with non-elastic bandages, and generic or custom-made compression garment use. Compression garments can vary in amount of compression, and it is important to note that the degree of compression varies from brand to brand. Adjuncts such as wraps, like ferro wraps, compression pumps, and intermittent pneumatic compression devices such as FlexiTouch can also help improve lymph drainage. Strict compliance with non-surgical treatment options is crucial to the management of lymphedema, both before and after surgery. Now we will review surgical treatments for lymphedema. There are 2 types of surgical treatments: physiologic procedures and debulking procedures. Physiologic procedures act to improve lymphatic drainage and mainly address the fluid excess in the limb. On the other hand, debulking procedures mainly remove the excess solid fibrofatty tissue that has accumulated as a result of chronic inflammation induced by inadequately drained lymphatic fluid. The main physiologic procedures are lymphatico-veno-anastomosis, or LVA, and vascularized lymph node transfer, or VLNT. The main debulking procedure used is dry liposuction. The Charles procedure and other similar procedures are usually reserved for the most severe of cases and is not commonly performed, so will not be discussed today. Candidates for surgery include those who have persistent lymphedema despite maximizing conservative therapies. Candidates must be compliant with recommended therapies and should not have had any active tissue infections within 1 month of surgery. Currently, the 3 surgeries most commonly used for lymphedema treatment are LVA, VLNT, and liposuction. First, we will discuss LVA, or lymphatico-venous anastomosis. This is also called a bypass. This is useful in stage 1 and 2 lymphedema when a large component of the swelling is due to fluid. In this procedure, blocked superficial lymphatics are identified by using ICG, the fluorescent dye, and SPY imaging. In order to improve lymph flow, we will bypass the blockage by diverting lymphatic flow into a nearby vein, which is identified using a vein finder. The drainage of lymph is rerouted by connecting the blocked lymphatics to nearby patent veins. This is done using an operating microscope with up to 10x zoom and sutures finer than a human hair. The vessels being sewn together are 0.5 to 0.8 millimeters in diameter and requires a surgeon skilled in supramicrosurgery. For optimal results from this surgery, the venous system should be normal, meaning there should be no clots and no reflux or venous insufficiency. This procedure takes anywhere from 2 to 4 hours and is not a very invasive procedure, since the veins and lymphatics being sewn together are just millimeters below the skin. The main risks of surgery include bleeding, infection, and anastomotic failure, in which case there may be minimal benefit from surgery. Patients usually go home on the same day after surgery. Postoperatively, patients wear a Class 1 garment continuously. Compression garments are adjusted or downgraded at 6 to 9 months postoperatively based on improvement. Patients are prescribed aspirin for 1 month and antibiotics for 2 weeks postoperatively. There's to be no heavy lifting or contact sports for 4 to 6 weeks, but light activity and walking is encouraged. Next, we will review vascularized lymph node transfer, or VLNT. This is useful in stage 2 and stage 3 lymphedema when the swelling is due to fluid and especially when there are recurrent episodes of infection. In this surgery, redundant or accessory lymph nodes from elsewhere in the body are borrowed and transplanted into the limb with lymphedema to help improve lymphatic drainage and decrease the risk of infection. In order to do this, the artery and vein that are necessary for the lymph nodes to survive are identified, divided, and reconnected to an artery and vein in the recipient limb. This way, living lymph nodes are transferred to the affected limb and will act as a pump to start drawing in lymphatic fluid from the surrounding area. These lymph nodes can also secrete growth factors that over time will induce new lymphatic channels to form. Donor sites for this surgery include lymph nodes from under the chin or submental, above the clavicle or supraclavicular, on the side of the chest wall or lateral thoracic, in the abdominal cavity from the omentum or jejunum, and in the groin, the superficial inguinal. When lymph nodes are removed from the donor site, other than from the abdomen, there is a risk of developing donor site lymphedema. Reverse lymphatic mapping is used to decrease this risk. A radiolabeled substance is injected into the space between the fingers and toes and is taken up into the lymph nodes, draining those extremities. The lymph nodes that take up most of the radiolabeled substance are identified, and only lymph nodes that take up 10% or less of the substance are deemed suitable for transfer. The risk of donor site lymphedema is about 2 to 3%. This procedure takes anywhere from 4 to 5 hours and requires a surgeon skilled in microsurgery. Patients usually stay in the hospital for 2 to 3 days so that the flap can be monitored and patients can work with physical therapy, since strict elevation of the arm or leg is required for the first 3 weeks. During this phase, no compression garment is worn because this can compress the vessel supplying blood to the flap and potentially injure the flap. After 3 weeks, continuous compression garments are required for at least 9 months postoperatively. Patients are prescribed aspirin for 1 month and antibiotics for 2 weeks postoperatively. Patients may resume physiotherapy at about 1 month post-op. No heavy lifting or contact sports is allowed for 4 to 6 weeks, but light activity and walking is encouraged after the initial 3 weeks. Finally, we will review liposuction, or suction-assisted lipectomy. This is useful in stage 2 and 3 lymphedema, as well as even more advanced lymphedema when the swelling is due to increased fibrofatty tissue. A technique called dry liposuction is used to remove excess fat, fibrous scar tissue, and some fluid through a series of small 3 to 4 millimeter incisions. This procedure reduces the limb size, and the immediate postoperative results can often be quite dramatic. Patients go home the same day or sometimes stay in the hospital overnight. Postoperative care involves wearing a Juzo Class 2 compression garment 24/7 continuously, except for showering, and taking prescribed antibiotics for 2 weeks. Manual lymphatic drainage may resume at 3 to 4 weeks post-op. Compression garments are adjusted every 3 to 6 months as needed for optimal fit. Finally, in some patients, a combined approach may be taken where multiple procedures are performed. The severity of lymphedema and whether the swelling is due to excess fluid or fibrofatty tissue will help determine which surgeries will provide maximal benefit. Some patients may need a staged approach, where liposuction is performed in stage 1 to address the tissue component before LVA or lymph node transfer are performed months to years later to address the fluid component. Sometimes multiple procedures are combined in one surgery to target lymphedema from multiple angles. Lastly, it is important to note that none of these modalities can cure lymphedema. These procedures can help the limb feel less bulky, heavy, improve lymphatic drainage, slow the progression of the disease, decrease the risk of infection, and decrease the need for complex decongestive therapy. For example, patients may not need to wear as tight of a compression garment, or they may be able to go longer periods of time without wearing the garment. However, some degree of maintenance with compression garments or manual lymphatic drainage is usually needed. A small group of select patients may no longer need garments, especially when treated early. Lymphedema prevention. At Stanford, we are also performing LYMPHA, or lymphatic microsurgical preventive healing approach, to shunt cut lymphatic channels to a nearby blood vessel, also called lymphovenous bypass, or LVA, to prevent lymphedema. These procedures are performed at the time of lymph node surgery, so there are no extra skin incisions. Axillary reverse lymphatic mapping is performed to map and preserve arm lymphatic drainage during axillary lymph node dissections or sentinel lymph node biopsies. Once the oncologic surgeon has removed the lymph nodes, there will be cut ends of lymphatics that usually scar down as they heal, thus blocking the drainage of lymph and causing lymph to back up into the tissue, which causes swelling. However, we can identify the cut ends of lymphatics by injecting the fluorescent dye ICG and visualizing it with an imaging device such as SPY or PDE. Oftentimes, there will be a few cut lymphatics, and if there are suitable veins nearby, we can connect the cut lymphatics with nearby veins to reroute the flow of lymph. Without the backflow of lymph into tissues, lymphedema can potentially be prevented or minimized. This procedure does not add any additional recovery time. There's minimal risk with the potential for substantial benefit and improvement in quality of life. Thank you for watching this educational video. We hope you enjoyed it, and we look forward to partnering with you in your lymphedema care.